Dok, sayo na. Dok, pinabaya ba tayo?
I'm just trying to explain it as easy as possible, okay? My exams are actually, it's not copy-paste. I also try to make new questions every year because over the years, I've been teaching every year, for 10 years, pero sometimes nakokopya ninyo yung exam eh. So the thing here is that what we're going to do is, my questions are very practical. The way, just like my siguro, I think, is so practical that sometimes you miss them. But anyway, you try to listen to my lecture, makukuha nyo talaga yan. Okay. You start with, this is a, what's his name? So, ang pangalan ka?
Anju.
Raman. This is Raman's bone. Okay. So again, we started with alignment. Okay. Before we, as I always tell you, you start from afar and then zoom in, diba? Yun ang lagi ko tinuturo sa mga residents. So from afar and then zoom in. So from afar, okay. So basically, you look at the spine. So what do I mean by alignment? Okay. You have two alignments. You get an AP and a lateral. Okay. So on an AP view, what do you expect to see? What deformities do you see in an AP view? Either to the right or to the left lang naman yan, di ba? So it's scoliosis. On the lateral view naman, it's more of kyphosis and lordosis. So in certain real situation, you have a combination of kyphoscoliosis. Okay, so sometimes nagiging hindi siya ganun ka-simple na kyphosis lang. Okay, so basically, the spine is supposed to be straight. Okay, straight would be, you can start from here, in yon, and going straight down to the coccyx. Okay, so it should be one straight line like that. So nandito yung buttocks and then ito yung cleft, diba? Okay. What I mean by plumb line, okay, on the AP view, if I'm putting a weight and a string here, it should fall sa center dito. So how do we say how much translation yung patient meron? Okay. Basically, if you look at the plumb line, it's supposed to be straight down here, and if the upper extremity, upper trunk is actually shifted, assuming here, nagiging off ang center niya, andito yung plumb line. Okay? Ibig sabihin from here, mag-drop siya dito. This one is something like a stable structure. It drops something like that. So, off-center siya, di ba? Okay? Imagine a scoliosis. So, tabingi ang scoliosis. So, off talaga minsan ng pelvis. So, nakaganyan sila. The good thing about the body is that the body tells to accommodate the natural gait, yung natural balance. So, for example, in scoliosis, for this one on AP view, tabingi siyang ganyan, may curve ka dito, but the body will compensate by not moving further down here. Okay? So, what does the body do? It shifts a little to the opposite side. Okay? Kasi kung ganyan yan sila, mag-curve ka dito, ang lakad nila is ganyan. What the body does is, kaya nagiging S or C shape siya. Okay, so that's on the AP view. Okay, on the lateral view naman, so Raman's skeleton, something like this. The cervical spine is kyphotic, lordotic, lordotic, kyphotic, lordotic, kyphotic. So look at the sacrum, it's kyphotic. Okay. So again, if you make a plumb line, it really falls down center. So for example, if the patient is actually pretty too kyphotic, the body will actually move forward. So the center of balance would be shifted anteriorly. Anterior in the sense that it falls pretty anterior to the L4. Okay, kasi ito yung parang pose natin. It goes straight down here. Okay, so if the center of gravity is shifted anteriorly, how does the patient walk? Forward. Okay. If it's shifted posteriorly, naka-extend. So therefore, it's crucial to maintain the balance, alignment on the sagittal spine cervical lordosis, kyphosis, lordosis. Okay. So for example, it's a kyphotic spine, a lordotic lumbar spine. Okay, and then nagiging kyphotic siya. What happens? So this is pretty common in osteoporosis again, in ankylosing spondylitis, whatever infection. The spine, instead of being lordotic, nagiging kyphotic. So the patient's center of gravity is actually shifted anteriorly, and the patient walks pretty much like this. But again, it's not always like that, because for example, if you have a normal structure sa top, the body will also try to accommodate by hyperextending. So therefore, mag-hyperextend na naman dito. So, or hyperlordosis siya. Those are the wonder about the spine, because it tries to accommodate. Okay? So, any questions sa alignment? So, yun ang first natin, alignment. Okay? So, we have a lateral view and an AP view. The next thing that you need to understand is that yung landmarks. We always start with landmarks. Okay? So, what are the landmarks should appear to be stable, di ba? Okay, because for example, if you use the nipple as the landmark, okay, if you have a mango and a watermelon, so watermelon, ang nipple area niya nandito na. So, you do not use that as a landmark, with due respect. Okay, so that is not a good landmark. Therefore, the stable landmarks should be stable. The landmark should be stable in the sense na constant siya. Okay. So we were talking initially about the lumbar spine. We talked about an L6, di ba? An L6. It's not common, but I see it every now and then. So this is the 12 thoracic. Ano ba? Baka nahulog na. So 1, 2, 4, 5, 6, 7, 8, 9, 10, 11. So natanggal yung 12. Okay. So natanggal yung 12. Okay. So floating rib kasi, di ba? So natanggal yung 12. So this is your 11th rib. Your 11th rib is palpable or not? Always. If you have a big patient, you cannot palpate it. If you have a thin patient, you can obviously palpate it. So what I do, okay, the landmarks would be the rib. Okay, so you can actually palpate for the 11th rib, and you can go further in because the 12th rib is somewhere right here lang. You can palpate for the 12th rib, okay, and then try to, assuming this is the 12th rib, try to identify the alarm and glide your finger straight down, and it articulates with the 12th thoracic vertebra. Okay, if this is the 12th thoracic vertebra, assuming this is the 12th thoracic vertebra here, assuming, so you can feel for the spinous process of T12. So you have a defect, you have an interspinous space. Distal to that should be your L1, L2, L3, L4, L5. So those are the landmarks. So what I do, I usually start from here. Ganyan, okay, sa baba. This one is also a good landmark. What is this structure? Iliac crest. Okay? The iliac crest. Okay. So the iliac crest, if you try to make a horizontal line from the tip of the iliac crest, it falls, transects, bisects which structure in the which level. Okay, may ruler tayo, wala no? So imaginary, ano? So between 4, 5. So between 4, 5 yan siya. Sometimes you can feel this one, spinous process of 4 or between 5. So the tip of the iliac crest bisects at somewhere between L4 and L5. Okay, so if I were to do a disc extrusion, discectomy at L4, L5, I usually use this as a landmark. Okay, and then make my incision. But right now, again, meron ng imaging so I can make my incision smaller. So we have imaging in the OR. So meron C-arm So C-arm is a fluoroscopic guided fluoroscopic guided imaging na alam mo talaga yung level. So landmark would be this one. Okay? So sa cervical spine, what landmarks can be used here? Carotid tubercle. Carotid tubercle corresponds with, it's where the pulsation of the carotid artery. So because of the constant pulsation of the carotid artery, merong deformity, mag-a-adapt yung bone. That's your carotid tubercle, which corresponds with C6. Hyoid bone. Hyoid. 4. So of course, kung may nakaganyan or something like that, meron pa ring variation. So what else? So what I mentioned earlier was that you have to also be familiar with the eccentric anatomic structures. Okay. It's not always like this. It's not always vertebral body spinous process. So this is your C1. Okay. Your C1 is composed of your anterior arch. Baliktad siya. So your anterior arch, which is located obviously anteriorly, and your posterior arch, which is this one here. You don't have any spinous process at C1, right? So it appears something like this, okay? So as you notice here, there is an articulating surface for C1 to the occiput, which is here, okay? So C1, C2 yan siya, okay? So what else? So this is your bifid spinous process, is always a good landmark for C2. So this is your bifid spinous process. So you can palpate this. So palpate mo dyan, and then if you go down further in our dissection, palpate for the spinous process. The flat surface here should be your C1. Okay, and then now it's not bifid anymore. Down to C3. The 3, 4, 5, 6 vertebral prominence is C7. So this is 2, 3, 4, 5, 6. This is 7. So in very thin individuals, sometimes they come in, complain to you, may bukol sa neck. Okay. Okay, here, down here. Usually, it's the spinous process that is protruding out. So you can use this as a landmark. In my experience, I find it confusing pa rin to palpate for C6 or C7. In some patients, dominant masyado yung C6 spinous process. So it's better to get a good radiologic exam to know where your level exactly is. Okay, so this is your, another good thing is on your x-ray pala. On your x-ray, I think T1 is always constant. First rib is always constant. T6 is always constant. Again, T12 is always constant. Unlike your L6, diba? It can be an L6 or it can be S1. So on X-ray, the first rib is actually right underneath your clavicle right here. Okay, so it articulates with your T1 agad. So if you're getting an X-ray, for example, use the first rib as the landmark. Okay, so you count from the top. I prefer, again, always counting from the top. Like for example, if I were to count the level in the cervical spine, I count from the top. I usually need to visualize which structure? C1, okay, or C2, okay, here. Okay, so this is C2, 3. So dito naman, I always count here. So if you have an X-ray right there, to know where the exact level is, sometimes merong condition dito, use the T1 as a marker, or you can use which structure? T12 siya. So may corresponding level siya. What else? So these are the landmarks that I usually use. A good landmark also, for example, intra-op, would be the transverse process. The transverse process is very important because you don't see transverse process significantly at T12. So usually it's very prominent at L1. So meron pa kunyaring rib dito. So wala ka ng, pag open mo dito, okay, pag open mo dito, nandito yung 12 rib. And if you go distally, biglang nawala yung rib. So the absence of the rib may signify that you're at the level of L1. So here, for example, merong rib. Pagdating ng ganyan, ang ma-feel mo, ang next would be something like this. So if you notice, the transverse process is totally different in the lumbar spine as you compare it on the thoracic spine. Very prominent siya, diba? So flat, and it goes flatter further distally. So 1, 2, 3, 4, and then 5. So this is the spinous process. Okay. Any question? Do you have a problem with odontoid kanina, no? Na-imagine niyo kanina yung meron tayong x-ray ng odontoid. Yung what view was that? Open mouth view. So ito yun siya. So open mouth view, i-drop nila to. So makita nila yung odontoid process right there. Merong C1 ba dyan? C1, C2. Anyway, C2. Kita ninyo yung odontoid. So ito. This is C1. Okay. So this is your articulating process for the occiput. This is your anterior arch ng C1. C2. Ayan, C2. Ayan, C2. This is nice, okay? So, if you notice here, this is your C1, this is C2. So, nag-articulate yung C1 sa C2. Okay? So, this is your odontoid process. If you do an open mouth view, nakita nyo kanina sa open mouth view, ang nakita is something like this, no? Diba? So, you visualize the odontoid process. Now, what you see is that there seems to be a space in between. So the cut is actually the space between the lateral masses of C1 here. May difference, may space, diba? So on the AP view, on the lateral view, meron ding space. Tingnan nyo, nakadikit ba sila? Hindi. Odontoid is actually not directly in contact with the posterior portion of the anterior arch. Again, this is the anterior portion of the anterior arch, posterior portion of the anterior arch. This is the odontoid. So this is atlanto-dense interval. So this is the atlanto-dental space. Space here. Okay. Kita nyo yan. Kita nyo sa ano. So you have a space here. Okay. So if we have a patient right now, nang what happens, meron siyang fracture sa odontoid process. So na ganyan. Nag-translate posteriorly. Okay. So this is very, very important because the higher we go up in the cervical spine, the poorer the prognosis. Mortality is very high. Okay. So that's why the good thing about the upper cervical spine versus a mid-thoracic spine is the spinal canal is not constant. Spinal canal is not constant thoroughly. The spinal canal in the upper thoracic spine is actually bigger and wider compared with the spinal canal in the mid-cervical spine. Nakuha niyo yung point. Ibig sabihin nun, merong allowable space for the spinal cord to play in the C1, C2 versus a C4, C5. Okay, maluwag to eh, malaki to. So later on, in our dissection, next week in our dissection, we will be able to identify yung cervical enlargement nandito sa loob ng spinal cord. So maluwag talaga yung spinal, yung ano natin. Okay? What else? Any question? Landmarks, saan ba tayo? Landmarks na tayo, no? Ano pa? Ano pang gusto ninyo? Okay, so any question? Okay, can we proceed with the vertebra na? Next, sige. So, another pa pala. Okay. Phone ko. Sa dami. Sa phone ko. So, if you look at this one here, ito pala yung foramen na sinasabi ko. Okay?
Ay, no din nga.
Okay?
Vertebral.
Intervertebral foramen.
Intervertebral.
So the foramen superiorly is bounded by the cephalad vertebra. The inferior
Boundary.
okay, sorry. The neural foramen is bounded superiorly by the pedicle of the cephalad vertebra, inferiorly by the pedicle of the caudal vertebra. Okay? So you have this space here. So this is where you have your nerve root. In our dissection pala, we will be able to identify the nerve roots clearly. Okay? So what we will do in our dissection part would be to do laminectomy, mag-laminectomy tayo. Laminectomy tayo, and then visualize the spinal cord. We prefer cutting from the cervical spine down here. In last year, we were able to really take out the whole spinal cord with a portion of the nerve roots sa side, and then we were. Ano na? Ayan, fuse yun siya. Matinikit. Fused. Yeah. Okay. Anyway, we were able to dissect the whole of that down to the phylum terminale, no? So we have specimens around. Wala na. Natapon na. Next week. So we were able to visualize the phylum terminale. Makikita nyo talaga yun siya. Okay? Sa dissectioning. Pati yung nerve root. So laminectomy. Mag-laminectomy. Merong iba doon na nag-laminectomy na sila. Nagdi-dissectomy pa. Merong ibang tinanggal yung disc from posterior. Okay? So, okay, so what else? Okay, ito yung sinasabi ko na house. Base ng house, floor ng house is the vertebral body. And then pedicles, and then lamina. Okay? So, the PLL is located directly, so ALL is here, anterior longitudinal ligament. So, ALL, vertebral body, PLL, spinal cord, ligamentum flavum, lamina. Okay? Kaya tayo further. Ligamentum flavum, and then ano yung interspinous ligament? Connecting the spinous processes, supraspinous ligament. Okay, so ALL, vertebral body, PLL, spinal cord, epidural fat, ligamentum flavum, lamina. Okay, tingnan natin lamina. So interspinous ligament, supraspinous ligament. So in our dissection, you will be able to visualize the supraspinous, interspinous. Okay, sometimes you can also visualize your intertransverse process ligament. So makikita rin yan mamaya sa dissection natin. May ligament pa dito. So ang nerve root, pag tinanggal nyo yung intertransverse process ligament, lalabas yung nerve root. Okay. So for discectomy, for example, what we do is we open up a small portion here, laminotomy, portion of the lamina, and then makita mo na yung nerve root. I-retract mo yung nerve root, tanggalin mo yung disc. Okay, so yan yung discectomy. We will do that sa next natin. Okay? So, review your, ano na lang siguro, your thoughts.